Thanks, Millie. I'm going to present the optimal use of anti-IL-12/23 for the management of IBD. I do have some relevant disclosures that are shared here for you and of course are also in the conference materials. My presentation and my comments though are all my own. So within the treatment options for moderate to severe IBD, we obviously have a number of different induction and maintenance therapies. We have now 3 different classes of biological therapies for the treatment of Crohn's disease and ulcerative colitis. And I'm going to spend time during this presentation highlighting what we've learned about Ustekinumab as an anti-P40 therapy, but also the emerging anti-P19 IL-23 selective inhibitors. So looking on the left, you can appreciate that there are several proteins that are shared by the cytokines IL-12 and 23, and specifically Ustekinumab is an anti-P40 antibody. And by knocking out P40, you're actually knocking out both the cytokines IL-12 and 23. Distinct from that is the P19 protein, which is only present in IL-23. So you note that the antibodies in development for IBD, Vedolizumab, Guselkumab, Mirikizumab, and Risankizumab, are anti-P19 therapies, and therefore they only knock out IL-23. As you can see in the tables, Ustekinumab is now approved for moderate to severe plaque psoriasis, active psoriatic arthritis, and then of course moderately to severely active Crohn's disease and ulcerative colitis, while Guselkumab and Risankizumab are both approved for moderate to severe plaque psoriasis, and Guselkumab got approval in the last year for active psoriatic arthritis. These therapies are in development for treating inflammatory bowel disease as well, and we've learned a bit about the treatments predominantly from the Ustekinumab data. The pivotal trials for Ustekinumab in moderate to severely active Crohn's disease were called UNITI-1, UNITI-2, and Immunity. On the left are those induction trials, UNITI-1 and UNITI-2, and you'll note that by design, UNITI-2 was predominantly and almost exclusively TNF-naive patients. And you'll also note that as we've seen in many therapies for IBD, when patients have not already failed other biological therapies and frankly other treatments, they tend to have higher remission rates as well as higher response rates. You'll also note on the right that the maintenance of remission with this therapy was quite substantial, as well as all the additional secondary endpoints. And these studies are what informed the decision to use an IV loading dose that is weight-based, and the maintenance dosing that in the United States is 90 milligrams every 8 weeks. In other parts of the world, they actually offer it as every 8 or every 12. And I'll note for you as well that the psoriatic dosing does not include a loading dose that's IV, but includes 2 closer spaced 45 milligram doses sub-Q and then 45 sub-Q every 12. So the dosing strategy for Crohn's disease came from these studies and have subsequently been supported in ulcerative colitis as well. Now, subsequently, a sub-analysis of those original studies demonstrated that, in fact, Ustekinumab at the every 8-week dosing was more likely to achieve an improvement in the SESCD, endoscopic improvement, as well as endoscopic response and what would be defined as mucosal healing. This is a sub-study in a smaller number of patients, but still important to understand that there's endoscopic improvement that's obtained with this therapy. Most recently was the completion of the STARDUST study using Ustekinumab in Crohn's disease, and this was actually a treat-to-target randomized trial of adult patients with Crohn's using endoscopy at week 16 as the decision point for dose adjustment, followed by the use of biomarkers to subsequently adjust therapy and assess response to the treatment. The objective was to investigate the benefits of a treat-to-target strategy with Ustekinumab therapy combined with this early endoscopic assessment. Really an important advance in our field to understand this further. The trial design is seen here, and it's a bit complex, but I'll just share with you that the endoscopic assessment at week 16 is what determined whether patients would dose escalate. And you can see in this design that patients were able to go all the way up to every 4 weeks with therapy and had continuing monitoring out to week 48, and then there's a long-term extension component. What was originally presented this past year at the European GI meeting was the primary endpoint. And what you'll note here is that despite the treat to target strategy, there was not a statistically significant result in the non-responder imputation analysis seen on the left there. But if you looked at the last observation carried forward, it did meet statistical significance using that endoscopic endpoint and subsequent adjustments in dosing intervals compared to standard of care. So this is similar to the CALM study, but CALM used a variety of different markers rather than endoscopy to adjust treatment dosing. You can also look further at the endoscopic outcomes at week 48 from STARDUST and appreciate that there were similar results, whether you looked at a non-responder imputation or last observation carried forward for both treat to target and standard of care. So you might want to know, so what's the benefit here of treating to a target or using endoscopy to gauge our adjustment of dosing? Well, if you actually look at more objective endpoints like CRP and correlate it to the serum concentrations of drug, there was actually improvement in normalization of CRP with higher levels of drug, suggesting that as the dose was increased and the serum concentrations went up in the right patients, the CRP was more likely to normalize. In other words, we were more likely to control the inflammation. So you can see that here at week 8 and even more dramatically at week 16. So there are some data that can be extracted from this to support this general strategy and understand how dose escalation with Ustekinumab might gain these results. In addition, there was a sub-study using endoscopic, not endoscopic, but bedside ultrasound to assess patients, and you can appreciate as well that they were able to demonstrate the utility of point-of-care small intestinal ultrasound to demonstrate response to the therapy with Ustekinumab. And of course, this is being done in Canada and Europe and a bit in Asia and just getting started in the US. So I thought this was of interest to share with all of you. Now, subsequently, people have asked the same questions we've had with all of our therapies for Crohn's disease, which is, does it work for perianal disease? A post-hoc analysis of the UNIFI trials demonstrated that, in fact, yes, Ustekinumab works well for perianal disease. Compared to placebo, there were more patients who had fistula response, which was a greater than or equal to 50% reduction in fistula drainage. And therefore, this likely has activity in the perianal area and can be used when needed or in a patient who has perianal disease. Remember that your patients with perianal disease should also be evaluated by your surgeon for an exam under anesthesia when it's anything more than a simple fistula. We at the University of Chicago have looked at our experience with dose escalation with Ustekinumab, predominantly in our Crohn's population. And in this large study, we found that 20% of our patients required dose escalation, which was determined by the physician's discretion and obviously the patient not responding to therapy. We did find that patients who did best with the dose escalation to a Q6 or more often Q4 week strategy were those who had responded during the loading phase and who just hadn't achieved remission, or who had actually been in remission but lost response. That's distinct from those who were true primary non-responders despite their first couple doses of this therapy. So dose escalation does seem to have some benefit in this real-world study from my center. One of the unique features of Ustekinumab that we certainly appreciate is its very low immunogenicity. Whether you look at the immunity study there on the upper left, the open label long-term extension out to 3 years, you can appreciate that there's a very low rate of anti-drug antibodies. And not only that, those who develop anti-drug antibodies don't come off drug. So this is an important observation and likely unique to the molecule, and therefore is why one of the reasons why we don't use this drug in combination with other therapies in most scenarios. So that's helpful to know. It may also let us do intermediate or intermittent therapy with this drug, where you would treat patients, and if there's a reason they needed to come off, we could go back to it without as much concern, although that hasn't been fully studied yet. In addition, there is a very nice study that was done from the Massachusetts General Hospital looking back at their patients on Ustekinumab or Vedolizumab and whether being on a concomitant immunomodulator improved efficacy or durability of therapy. And I want to point out to you that the results suggested there was no additional benefit of staying on an immunomodulator when you got to these therapies. Both Ustekinumab and Vedolizumab are thought to have low immunogenicity, but also by the time patients have gone through other treatments to get to these, there doesn't seem to be much benefit in leaving them on concomitant immunomodulators. I use both therapies now predominantly as monotherapy in my own practice. The other point that's been raised is, what about patients who've had actual antibodies against TNF? So they've demonstrated that they are patients who are more likely to develop anti-drug antibodies. And if they've done so with one anti-TNF, we've learned previously that they're more likely to have antibodies against the second anti-TNF. Well, interestingly, in a study that was organized with the data from Prometheus Labs, they were able to show that although the patients who had antibodies to one anti-TNF were known to be higher risk for subsequent anti-drug antibodies within that class, when they went to Vedo or Usta, they did not develop those antibodies. So if you're wondering whether you needed to use concomitant immunomodulators when you have already developed immunogenicity to anti-TNF, the answer looks to be no. And this was very reassuring, presented at DDW this past year. Now, in terms of where to position these drugs, there's a nice systematic review and network meta-analysis that suggested that adalimumab and ustekinumab were ranked highest for induction of clinical remission in patients who had already been exposed to anti-TNF. Ustekinumab had the lowest risk of serious adverse events and infection. Now, meta-analyses and network meta-analyses have their limitations, as I'm sure you appreciate. So let me show you another study. This is a study in which patients were prospectively followed with Crohn's disease and had already failed anti-TNF. They were then observed while they were either on Usta or Vedolizumab, and in the assessment of steroid-free clinical remission, biochemical remission, and drug survival, staying on the drug as a marker of success, the patients on Vedolizumab did less well than those who were on Ustekinumab, suggesting Usta is a superior option after TNF failure in your patients with Crohn's disease. Now, looking on to UC, Ustekinumab is approved in the US, as I mentioned, for moderate to severe ulcerative colitis, and its development program was called UNIFI. I've already told you that the dosing schedule for induction and maintenance is similar to what we know in Crohn's, a weight-based IV loading dose of approximately 6 milligrams per kilogram, and then maintenance of 90 milligrams every 8 in the US. And you can see the pivotal trial data here, including the successful clinical remission at week 8, followed by remission, clinical response, and endoscopic healing of responders who went on to the maintenance study. Unique to the UNIFI trial across all of our IBD studies is the incorporation of a novel endpoint called Histo-Endoscopic mucosal healing, which is summarized in the turquoise box there for you, where you appreciate that the endoscopic appearance of 0 or 1 plus a histological finding of less than 5% neutrophils was defined as the histoendoscopic mucosal improvement or mucosal healing. And you can appreciate here that the 90 milligrams every 8 weeks was clearly superior to placebo, numerically better than the every 12 weeks, not powered to specifically compare those, but this is a very important endpoint. Subsequent analyses demonstrated that of patients who achieved the histoendoscopic mucosal improvement by week 8, they are more likely to have that at week 44. Not a surprise to hear that. This is clearly an interesting and important endpoint. Now, we've also seen how rapidly patients respond to the IV ustekinumab with ulcerative colitis, just showing you on the left how quickly stool frequency drops in the patients who are actually receiving drug, which are the purple lines, as well as how quickly patients have cessation or improvement of rectal bleeding, which is the shift to the darker blue parts of these stacked bars on the right. It's a rapidly acting therapy. You can imagine that for a patient suffering from UC, knowing that by 2 weeks, they may notice already that their bleeding stops and their frequency improves significantly. There's long-term safety data and long-term efficacy data with Ustekinumab and UC out to 2 years now reported. And you can see of those patients who responded initially and went through maintenance phase, they have a very low likelihood of losing response over time. And this is very reassuring, and the safety of this drug continues to be quite favorable. There are a number of real-world studies that are all summarized here for you. You can appreciate that whether this is a study in France, 2 studies in the US or Germany, we have quite significant 3-month and even 12-month clinical remission results in a population who had almost all failed biological therapies on their way. Now, also asked is whether patients can tolerate this during pregnancy. Reported out are the pregnancy data, which are both from the IBD experience as well as from the psoriasis and psoriatic arthritis. Of a large number of pregnant patients, you can appreciate that their outcomes are similar to the general population, which supports that this is a therapy we can use in pregnancy. One question that comes up is whether joint pain would be a contraindication for Vedo or Ustekinumab. IL-23 is not expressed on joints. So you have to be thoughtful about whether this patient has joint pain because their bowel is inflamed and they're likely to improve, and really understand that a bit more before you consider using this therapy. If the patient has arthralgias from their bowel inflammation, then of course this is a very good option. But if they have arthritis, you might be considering a different treatment option for those patients. Now, very briefly, I just have 1 or 2 slides on some of these other therapies in development, which I told you are very interesting. The anti-P19 therapies offer a selective IL-23 inhibition, and you can appreciate here in this phase 2 trial of Vedolizumab that it achieved clinical response and remission in patients with moderate to severe Crohn's. Interesting here and published by Bruce Sands was that serum IL-22 levels, when elevated, predicted response to Vedolizumab, the IL-23 inhibitor. And this suggests that we might be able to use this as a biomarker in the future. And of course, we're interested in further validation work to look at this. So in other words, obtaining a serum IL-22 level before treatment with an IL-23 might tell you they're more or less likely to respond. And this might help us sequence our therapies. So a very interesting result that we're excited about. Looking at Mirikizumab, this has now been studied in both UC and Crohn's disease, and you can see the phase 2 results here. Interestingly, on the left, it wasn't the highest dose of Miri that worked best in UC, but rather the dose of 200 milligrams. On the right, you can see a more classic dose response that we've seen in the Crohn's disease population there, and this is an endoscopic response, very importantly. Risankizumab is also in development. This is the data from the moderate to severe Crohn's disease study, and you can appreciate here what looks to be a dose response in remission on the top and response on the bottom. The 600 milligram Risa dose is the darker shade of blue, not the full dark blue, which is all the Risa patients, but rather the slightly other shade there. And this obviously is a therapy moving forward, and we're excited about this. And my very last point is just to suggest to you that P19 inhibition may be better than IL-12, IL-23, P40 inhibition. There are a number of head-to-head studies in psoriasis demonstrating this. You can see on the left and on the right that Risankizumab at higher doses was superior at achieving the control of psoriasis measured as a PASI 75% or a PASI 90 than Ustekinumab. So suggesting the P19 inhibition may be more effective than P40. Similarly, Risankizumab looked better than adalimumab for psoriasis. So will these P19 inhibitors be better than the P40 and better than anti-TNF, or at least injectable anti-TNF, in our IBD population? Will be very interesting to know. So in summary, you've seen some of the data, and I hope this has given you some insight into how you might consider these therapies. The IL-12/23 therapy, Ustekinumab, has been demonstrated to be effective in Crohn's and UC, and we have a number of emerging P19 therapies that seem to have similar benefits. It is true that about 20% of our patients need dose escalation with Ustekinumab, not a surprise given what we've learned about all of our IBD therapies. And I would suggest that you position this earlier works better. TNF naive works better. Certainly patients who have skin manifestations of their IBD would be a great population to consider. And the favorable safety and low immunogenicity certainly support us using these therapies in that setting. And I showed you some of the data to suggest that this would be a good option as your first choice after TNF failure as well. I hope that this has been helpful, and I'm happy to hand this off now to Bincy and to discuss this during our panel. Thank you.